Welcome, and thank you for joining us today. We will soon meet with Dr. Sukrithan to learn about Azedra and our key learnings after these past 5 years. My name is Eli Soto. I'll be your moderator for today. I'm a board member of the Pheo Alliance, and I'm a patient myself. When it was discovered that I had a metastatic pheochromocytoma, it was estimated that I had it for approximately 10 plus years. Now I'm currently in relapse, and like many of you, I'm also curious about, all the available treatment options that there are out there, which makes today's very apropos. So I'm here with Dr. Vineeth Sukrithan, and we will provide him a proper introduction in a few moments. This program today is brought to you by the Pheo Alliance, whose mission is to empower patients with pheochromocytoma or paraganglioma, their families, and medical professionals through advocacy, education, and a global community of support while helping to advance research that accelerates treatments and cures. I want to give a special thanks to Lantheus Progenics for making this webinar series possible through through an educational grant. I have some upcoming events that I want to go ahead and share with you guys. Our next monthly peer support meeting will be August 1st at 7:30 p.m. Eastern Standard Time, 4:30 p.m. Pacific. You could register via our website at pheopara.org. These are nice because patients like us, we're so rare, and it's a really good opportunity to meet with others like you. Also, we'll be holding a series of in-person regional conferences this year. These are great for learning about the disease state itself and management of treatment through physicians who present to the patients. The dates and the locations are as follows. So we've got the next one coming up is going to be in Omaha, Nebraska. That's just right around the corner at August 12th. Then we have one following in September on the 9th in Bethesda, Maryland, followed by October 28th in Gainesville, Florida, and then Phoenix, Arizona. That's TBD at the moment, but looking somewhere around November, December timeframe. Space is limited, so go to our website and register for a conference near you today. And then the fourth annual Pheopara Awareness Week will take place August 21st through 25th. Keep an eye on social media for information on what we have planned and how you can be a part of it. So Dr. Sukrithan is going to go ahead and present for about 30 minutes. Then we'll have time and room for Q&A from the community. We will ask the questions that were submitted to us beforehand. And if you didn't get a chance to, you can also type your questions into the chat section, and we'll do our best to have all of your questions answered if the time allows. Many people we've seen this before, they're going to ask a lot of variations of the same type of questions, so we're going to listen carefully to try to filter it out and condense it to the same theme of the question. We'd also appreciate any questions that are less case specific. We don't know your case history specifically in the broad context, so it's better if they're just more general and generic if possible. Little disclaimer, the contents of this and all episodes of the educational webinar series are not influenced by our sponsors, and this is presented independently by healthcare professionals. The information presented on this webinar is for educational purpose only and should not substitute the advice of your doctor and medical team because they have an in-depth knowledge of your specific medical history and your current situation. So without further ado, I'd like to introduce Dr. Vineeth Sukrithan. He's a medical oncologist at Ohio State University Comprehensive Cancer Center, otherwise known as the James, specializing in the study and treatment of neuroendocrine cancer, thyroid cancer, and adrenal cortical cancer. He utilizes chemotherapy, molecularly targeted oral medications, novel immunotherapy, and peptide receptor radiotherapies in the treatment of these unique types of cancers. In addition to his clinical work, he's also a member of the Translational Therapeutics Program at the James and the co-director of the Adrenal Tumor Clinic. He was recently selected to lead an externally funded effort through the International Thyroid Oncology Group to operationalize a multi-institutional registry database for patients with medullary thyroid cancer. He also serves as assistant professor in the Division of Medical Oncology at The Ohio State University and has completed his postdoc fellowship in the clinical research at Johns Hopkins University. His research has been published in numerous peer-reviewed journals, including Cancer Research, American Journal of Clinical Oncology, and Clinical Lung Cancer. Dr. Sukrithan, welcome.
Thank you so much for that very kind introduction. I'm going to share my screen so that we can start our presentation. Are you guys able to see the presentation?
Not yet.
What about now?
Yep, it's coming online. There it is.
Okay, wonderful. Thank you so much for the kind introduction once more. So my name is Vineeth Sukrithan. I'm an assistant professor of medicine in the Division of Medical Oncology here at the Ohio State University Comprehensive Cancer Center in Columbus, Ohio. It's a pleasure and a privilege for me to be able to talk to you guys about considerations for treatments with Azedra, a medical oncologist perspective, and what we've learned over the last 5 years or so. These are my financial disclosures. I also want to acknowledge my colleague, Dr. Bhavana Khanda, as well as Akram Hussain from pharmacy for some of these slide presentation materials that I will be sharing with you today. So iodine-131 ibenguane, also sometimes called MIBG, as some of you may be familiar with, which stands for meta-iodobenzyl guanidine. It's quite a mouthful. But ibenguane, iodine-131, is a compound, it's a radiopharmaceutical compound that has structural similarity to norepinephrine, as you can see here. As we all know, some paragangliomas, pheochromocytomas and paragangliomas do produce norepinephrine. This is a schematic that shows how it looks. So norepinephrine is produced by the tumors, and it has two functions. One, as we all know, it's a neurotransmitter, and it also has hormone-like function. So what it does is the norepinephrine interacts with the receptors, the adrenergic receptors called alpha and beta receptors, and this causes classic sympathetic nervous system effects such as sweating, palpitations, high blood pressure, anxiety in some patients. Now, the norepinephrine that's not taken up by the adrenergic receptors is recycled by something called the norepinephrine transporter. And this recycled norepinephrine is stored in a synaptic vesicle that is shown here, or it's broken down by an enzyme known as monoamine oxidase. And so this is how the norepinephrine functions in our body. Now, because MIBG has such close structural similarity to norepinephrine, it is also taken up by the same norepinephrine transporter, is transported into the tumor cell. And the iodine-131 has the ability to basically produce radiation after it undergoes radioactive decay, and administering a lethal amount of radiation into the tumor itself, thereby allowing a very targeted delivery of radiation into the tumors, thereby killing them. So this is the basic mechanism of how iodine-131 ibenguane works. Now, this compound, the iodine-131 ibenguane, has been around for some time in a formulation that we called low specific activity iodine-131. Unfortunately, this has some disadvantages, which the high specific activity compound formulation that we call Azedra now is able to overcome. So what are some of the older disadvantages that low specific activity iodine-131 had? So first of all, it is produced by a different process known as isotope exchange. And what it led to was a product that had a ratio of radioactive MIBG and non-radioactive MIBG in a ratio of 1 to 2,000. What it means is that many of the MIBG molecules came out not radioactively labeled with iodine-131, leading to less efficacy. So, the non-relabeled MIBG, we sometimes call it cold MIBG, tended to compete with the radio-labeled hot MIBG, and this really reduced the effectiveness of the compound as a whole. Now, at the level of the transporter itself, when there's a lot of this cold, non-labeled MIBG, what it would end up doing is to prevent the reuptake of the norepinephrine itself. And unfortunately, this would lead to exacerbation of manifestations of catecholamine excess like sweating, palpitations, blood pressure, and anxiety. Now, all of these side effects of the older formulation have now actually been overcome by the high specific activity iodine 131, which has some unique advantages. First of all, high specific activity iodine 131 ibenguane has more than 99.9% of the MIBG that is labeled with the radioactivity. So it no longer needs to compete with the non-labeled MIBG. Therefore, it is highly efficacious and extremely potent. So if you look at the cellular uptake of the radioactivity, it actually is 150 times that of the low specific activity iodine 131 MIBG. And it represents a big improvement in this compound. And in terms of the actual, the dose, around 2,500 millicuries radioactivity is contained within every milligram of the high specific activity, compared to just 16 in the low specific activity. And because of the lack of competition with the cold MIBG, we no longer see an exacerbation of catecholamine related side effects with this compound. So it has been really a quantum change in this treatment landscape. Before I go ahead and explain and we go through the details of the trial that led to approval, I want to make sure that everyone has a good understanding of the phases of clinical trial. So a phase 1 clinical trial is done with the purpose of looking at safety of the medications that are new and dosages, finding the right dosage of the medicines. These tend to be smaller trials, maybe 20 to 100 patients. It lasts on average sometimes months to years. And 70% of drugs that enter phase 1 are successful, and they pass on to what's called a phase 2 trial. The purpose of a phase 2 trial is to also to look for efficacy, to make sure the medication is efficacious and that it's safe. These tend to be larger trials, which can have a few hundred patients, and sometimes they can be longer lasting. So the length of the study can be anywhere from several months to many years. And around 33% of medications that are in a phase 2 trial reach their endpoint, and then they are eligible for a larger study, which we call a phase 3 trial. A phase 3 trial, the main purpose is to compare it to a different other treatments to see how efficacious it is and how safe the medicine is. These tend to be much larger, sometimes hundreds to thousands of patients. The length of the study can be anywhere from a couple of years to up to 5 to 10 years even occasionally. And sometimes 25% of patients, 25% of medications rather, that are studied in a phase 3 trial end up getting approval. So as you can see, it's a long and arduous process, and not every medication is able to finally meet all the stringent the endpoints and attain FDA approval. So how do we evaluate a response in a clinical trial? How do we know if a medicine actually works? So there are many endpoints that we'll discuss and that are that are mentioned in a lot of studies, and I want to go through them briefly. So complete response is when all the tumors that we know of in the trial, when we start the patients off on a new medication, if they completely resolve and are no longer seen, that's called a complete response. Now, a partial response is when the lesions that we know of at the beginning shrink quite considerably in size. So there's also a good response that we call a partial response. A stable disease is when they don't have a meaningful change, meaning the tumors kind of basically remain in the same ballpark in terms of size. And finally, progressive disease is when, unfortunately, either the tumors increase in size or we start to see new spots show up, which we call progressive disease. Now, there are a few other endpoints in clinical trials that's worth mentioning. You'll hear the term progression-free survival being used a lot. What that really means is how long from the start of the treatment do patients live without the cancer growing or getting worse? So that's what it means. We call this a surrogate endpoint because sometimes in slow-growing cancers, progression-free survival is an easier endpoint to measure compared to the other endpoint, the overall survival. Overall survival, as the term indicates, is basically ask the question, how long do patients live on the study treatment period? So it's a much more simple and straightforward endpoint to measure. Objective response rate is what percentage of patients have at least a 30% decrease in the size of the tumor on study treatment. This is a standard definition for measuring a response to a tumor, to a new treatment. And lastly, so the objective response rate. So moving on to Prima et al., which was the trial that led to the approval of Azedra. This came out in around 2018, 2019 timeframe, which essentially studied high specific activity iodine 131 ibanguane in pheochromocytomas and paragangliomas. So this was an open label trial, which means that the patients who were enrolled were aware that they were on this particular active agent. Single arm prospective study. 68 patients received at least one dose and were eligible for follow up. The primary endpoint that the researchers were trying to measure was a 50% reduction in the antihypertensive blood pressure medications. We know that this is a very important endpoint for many of our patients because high blood pressure is associated with the increased production of norepinephrine by these tumors. So a 50% reduction that lasted for at least 6 months was considered to be a good endpoint to measure in folks who are getting the Azedra treatment. Secondary objectives that they also looked at were things like what I already mentioned. So tumor response rates, biochemical responses in the blood work, overall survival, as well as safety. The study procedure, the key inclusion criteria was that patients who were at least 12 years of age and had a diagnosis of pheochromocytoma paragangliomas, who are ineligible for any curative surgery, and who had failed prior treatments and were not candidates for chemotherapy were considered to be eligible for the study. All patients needed to have been avid on an MIBG scan. This is very important to keep in mind. And on a stable anti-blood pressure medicine regimen for at least 30 days. The way this medication is administered, as we'll see in the future slides, is first a smaller dose is administered as a dosimetry, as we call it. Anywhere from 3 to 6 millicurie is the amount of radioactivity that's administered. And later, up to 2 therapy cycles, 3 months apart, was administered as part of this trial. So who are the patients who got on the study? So the patients were a diverse group of patients. 90% of whom had prior surgery before. 30% of patients, in fact, had gotten conventional low specific activity iodine 131 on this trial. Close to 40% of patients actually even had chemotherapy, including with a regimen that we call CVD, which is a standard chemotherapy IV regimen that we use. And many of the patients were heavily pretreated. So as you can see, around a third of patients had gotten 2 prior lines of treatment. Another third had gotten even 3 and even 4 lines of prior treatment. So this was a population that was not treatment naive, meaning they had gotten a lot of treatments before. The patients had metastases in multiple areas of the body, including lymph nodes, bones, lungs, liver. And so we think that this is a population that is close to what we see in clinic. Coming to the results, 25% of patients met the primary endpoint, meaning they had at least a 50% reduction in the anti-blood pressure medication use that lasted for at least 6 months. The median duration of response, that means how long this endpoint was maintained, was around 13 months or so in the average person. The objective response rate, meaning the shrinkage of the tumor by the criteria that I mentioned prior, was seen in 23% of patients. Median survival, meaning how long does the average person have a prolonged life for, was anywhere from 44 months if the patient received 2 doses to 18 months if they received 1 dose. Now, this is again showed in this table here. It's important to realize that the best response rate that we found in patients were patients who completed both doses. So if you look at just that population, 30% of patients had 30% had a response rate as compared to no patients who got only 1 dose. So it's important to understand that getting both doses is very important in our patients. So what about the side effects? So the most common side effects, they can either be in the blood work or they can be symptoms. So in the blood work, the most common side effects were low platelets, which we call thrombocytopenia, low hemoglobin, which we call anemia, low white blood cell count, leukopenia, and low neutrophil count, which is called neutropenia. In terms of the actual symptoms that patients on the trial experienced, nausea, vomiting, fatigue, dry mouth, and dizziness were the most common adverse events, most of which tended to be lower grade, meaning not that severe and not requiring hospitalizations. It is important to know that there are certain adverse events that were severe, specifically relating to the blood work. So hematological serious adverse events were found in 70% of patients. So this is something that we counsel patients beforehand, that keeping a very close eye on blood work is very important. Around 25% of those patients required some supportive care, including blood transfusions, GCSF, which is a way to boost the white blood cells, and erythropoietin to boost the red blood cells. Also important to keep in mind is that, unfortunately, as we know, many of our patients have a heavy amount of disease in the bones, and there is some radioactivity that can get administered to the bones and the bone marrow during this treatment. So myelodysplastic syndrome, which is really a bone marrow toxicity, which can be pre-leukemic, was found in 4% of patients. 3% did in fact have leukemia from that, and another 3% of patients have blood clots in the lungs. So this is something to really discuss closely with your doctor before we start this treatment. Now, so high specific activity iodine 131 ibogaine, also called Azedra, was approved in July 2018 by the FDA as part of, based on the data that I presented to you, specifically for unresectable, advanced or metastatic pheochromocytomas and paragangliomas. It is to this day the only FDA-approved treatment that we have in patients who are either adults or pediatric patients more than 12 years of age. Important to keep in mind that the scans need to be positive when we do an MIBG scan, because that's an indicator that the norepinephrine transporter is present on the surface of the tumor, that it's functional, and then that the iodine 131 MIBG will home in on the tumor and it will be taken up by the cancer. So that's important first step. And also to keep in mind that this is a highly individualized treatment based on dosimetry, which I'll explain in detail in the next few slides. So after approval, it was a pretty large multidisciplinary team effort to get it institutionalized and started at the James. So we first had discussions with nuclear medicine, nuclear pharmacy, medical oncology, which is ourselves, and endocrinologists, and as well as our colleagues from radiation safety and nuclear pharmacy. We got approval from our pharmacy and therapeutics committees. We also had the dosimetry and treatment protocols that were approved by the institution, as well as we had intensive education of both our inpatient team as well as the clinic team about, what this treatment entails. And finally, we have a multidisciplinary approach, which includes radiation safety, nuclear pharmacy, nuclear medicine, ourselves, and we, approach this as a very important team effort to get the best outcomes for our patients. So this is what the workflow looks like for someone who sees us in clinic and is being evaluated for Azedra treatment. So the first step is education, because it's vitally important that everyone understands some of the data around efficacy and toxicity that I've already showed. Next, we do what's called medication reconciliation to make sure that you're not on any medications that can have interactions, and we'll talk about that as well. We explain the dosimetry procedure, and we set up patients for the dosimetry. We prescribe the potassium iodide, which is very important. This is the medication that blocks the thyroid from taking up the iodine, radioactive iodine, during dosimetry and treatment. This essentially protects the thyroid. And we also make sure that the patients are highly optimized from a blood pressure standpoint before we move on to the next steps. So step number 2 would be to make sure that the blood work is perfect and that you meet all the criteria to get the medication. So platelets of 80,000, neutrophil count of more than 1,200, and kidney functions also need to meet a certain threshold. We also, in parallel, start the approval process, which is, treatment plan is signed, paperwork is done, and we submit it to our team. And once we have approval, we reach out to our nuclear medicine and nuclear pharmacy colleagues, and we set up appointments To do the medication reconciliation and to stop medications that need to be stopped before treatment, and to set up dosimetry appointments and treatment appointments. We also have phone calls that are administered by our nursing team to make sure that patients are aware about their final appointments, that they've picked up their potassium iodide, and that we have scheduled them for all of their follow-up appointments. Now, dosimetry is basically a way to make sure that we are administering the right dose to the right patient. What it entails is administering a smaller dose and then measuring the amount of reactivity that is taken up by vital organs. The amount of radioactive dose administered depends on the patient's body weight. So for patients who are 50 kgs or less, which can happen in pediatric patients, it's 0.1 millicuries per kg. Whereas for patients who weigh more than 50 kgs, we usually use a standard dose of around 5 to 6 millicuries for the dosimetry. Before we do dosimetry, and in fact any other treatments, it's important to understand that we have to stop medications that can affect the norepinephrine reuptake and storage. The reason for that is it also limits the amount of iodine 131 Azedra iobenzine that is absorbed by the tumor. So we have to stop these medications for at least 5 what's called half-lives, which is a way to know for how long these medications remain in the body. And this is done both before dosimetry and therapeutic dose. We also make sure that it's not resumed until 7 days after a dose. So that's an important thing that patients are educated about. Now, there's a long list of medications that potentially can interact. So it's important to understand that certain CNS stimulants or amphetamines have to be stopped. Certain antidepressants, including amitriptyline, bupropion, mirtazapine, venlafaxine, certain reuptake inhibitors like phentermine, certain even pain medications such as tramadol, antipsychotic medications, other monoamine oxidase medications used to treat depression, non-selective beta blockade like labetalol needs to be stopped, calcium channel blockers, which are blood pressure medicines, as well as certain alpha and beta receptor agonists, stimulants, and certain sedating antihistamines also need to be stopped. So this is something that we rely on nuclear pharmacy, our colleagues who do a very good job and thorough job of giving the patients a call and making sure that any of these medicines, if they are on them, that it's stopped at an appropriate time frame. So this is what this is a schema of what a dosimetry looks like. So the first thing we do is to make sure that medication reconciliation is done and certain medications that need to be stopped are stopped appropriately. Following that, we schedule our patients out on 3 alternate days, on a Monday, Wednesday, and Friday. On a Monday, our patients come in, but before they do, they're advised to start the potassium iodide tablet a day before and to drink plenty of fluids to keep their kidneys functioning well. And on day 1, which is usually on a Monday at our center, they are given the dosimetry dose, the small dose of 5 millicuries, and pictures are taken with gamma scanners. And then another image is taken on Wednesday, and a third image is taken on a Friday. And using the images, we are able to do what's called a dosimetry calculation. And that's an example of this is shown here. Essentially, what it does is the gamma camera scan images are assessed to make sure that there is no radioactivity that is absorbed by important organs, namely kidney, liver, lungs, bone marrow, and intestines, that is more than a safe dose. So there's a calculation that is done for each of these organs, and the appropriate dose is found by reducing it to make sure that no individual organ ever gets more than the safe dose of radioactivity. And so this is what the purpose of the dosimetry calculation is all about. Now, treatment itself, after the dosimetry is done and we find the right dose for the patient, is usually, as I've said, 500 millicuries if there is no limiting radioactivity uptake by the organs. Or if there is, it is reduced to what the appropriate dose is. And sometimes for patients who are based on their weight, if you're less than 62.5 kgs, in pediatric patients, again, it's given at 8 millicuries per kgs, whereas for adults, the full dose is 500. So as I mentioned, thyroid blockade is first done with potassium iodide tablets 24 hours before and continued for up to 10 days after. Patients are also instructed to maintain adequate hydration starting 1 day before and for 7 days after. And blood work is done to ensure the platelets and neutrophil counts are where they need to be. So patients who meet these criteria are then administered the treatment as an inpatient. So after this communication is done and the confirmation of potassium iodide and fluids has been done, patients at our center come in on a Monday. They get admitted. IV fluids are started, labs are started, inpatient teams alerted, and the iodine 131 is administered the next day along with 3 medications, mostly to prevent nausea and vomiting, and that usually does the trick for a vast majority of folks. Now, after the treatment is administered as an inpatient, patients are observed in the hospital in an isolated room to make sure that the amount of radioactivity that's in their body is coming down nicely, and then that at the time of discharge, usually around day 4, day 5 or so, the dose rate that they're emitting is less than 7 milliroentgens per hour at a 1 meter distance. And at that point, you're basically safe to be able to discharge and go home into the community. We provide patients with blood work to be done, and blood pressure monitoring is asked at the time of discharge. And then 2 weeks after the treatment, we see patients in clinic to see how everything went. So post-therapy, we provide patients with lab slips and a clinic visit 2 weeks after. We monitor the blood counts very, very closely until we start to see a recovery. Sometimes that can happen at week 4, week 6, sometimes even up to week 8. Blood pressure log is kept by the patients. And after we see the patients, we set them up for another scan around 10 weeks or so to see if we've had a good response with just 1 dose or not. Now, moving on to the second dose, some patients require dose modifications. Not everyone can get the full dose the second time around. The basic criteria is to make sure that the blood counts, mostly the platelets and the neutrophil count, should have returned to baseline before we administer the second dose. But it's also important to keep in mind that if at any point the platelets, let's say, go less than 25,000, or a neutrophil count of less than 500, or anemia that is very severe and lasting for more than 7 days, or a low neutrophil count along with the fever, or platelet count of less than 50,000 associated with bleeding, if any of these criteria happen, that we reduce the dose to either 425 for the second dose or 85% of the first dose which is administered. Another point to keep in mind is occasionally, very rarely, we can see some pneumonitis, which is inflammation in the lungs. It's very clear that if that does happen, then we should stop the treatment after the first dose and not administer a second dose. So the actual administration of the dosimetry dose itself, the vial is essentially thawed to room temperature over 90 minutes or so, diluted with saline in a 10 ml syringe, and is administered over 1 minute, so fairly quickly. The therapy dose is a much larger dose, so it's 2 to 3 vials that need to be thawed, administered in a 60 ml syringe or so over 30 minutes for adults. This is a picture provided to us by my nuclear pharmacy colleague. So shielding for the dose injection is done through this apparatus that I've shown here. And it's also important to know that radiation safety preparation of the room has to be performed. So we have, this is a picture from our facility. We have a private room here with where this room is essentially, all the surfaces are covered with disposable materials to prevent any radioactivity contamination. And patients have access to a private bathroom as well. I want to give an example of a patient. So this is a 50-year-old male patient who came to us with tongue deviation initially. And he had a history of high blood pressure, palpitations, sweating, as we know. It did take a couple of years before the diagnosis was made, unfortunately. He did have some deviation of his tongue, ear pain on the right side, and hoarseness, along with cranial nerves were not functioning well in the 10th, 11th, and 12th cranial nerves. So an MIBG scan was done in 2014, and as you can see here, there was a mass that was found in the abdominal region, the retroperitoneal region, as well as on the skull base, and a few bony metastases. The patient was started on alpha blockade to control the blood pressure, and surgery was performed for some of these sites, followed by radiation. And he had a very nice response to this. In fact, the palpitations and the sweating episodes actually resolved. And the patient was continued surveillance for 5 years, happily. Unfortunately, at the end of that, he did start to develop new spots in the bones, as you can see here, which is more clearly seen in the FDG PET than the MIBG scan. But it was positive on the MIBG. So we did go ahead. Iodine 131 ibenguane was offered. And as you can see here, after 2 doses of iodine 131, he had a very nice response. The skull base lesions have really responded nicely. You can just see one of them here. Many of the bony spots have completely resolved. So this patient thankfully had an excellent response to the Azedra in this case. So I wanted to end by just highlighting certain challenging situations that I think are worth discussing and brainstorming for the future. So one of them is MIBG negative disease. So we do know that unfortunately not everyone has MIBG positive disease, meaning when you get the scan done, the tumors don't take up the tracer. So 30% of SDHB mutated tumors are actually known to be negative on MIBG scan. And this is especially unfortunate because we do know that sometimes SDHB mutated tumors tend to be more aggressive. So this is, I think, an unmet need in the field about what can we do in these patients who don't have uptake on the MIBG scans. Are there ways to change the tumor biology in any way and maybe make this an option for these patients in the future? But as of today, I think it is an open question. The second big question and a challenging situation is how to sequence treatments. So we do know that one of the main side effects of the Azedra or any radioactive treatment for that matter actually is the low blood counts. And we know that chemotherapy also has similar side effects. So CVD chemotherapy can exacerbate low blood counts. So I think we need to have a discussion with patients about, if you are eligible for both, it makes sense to make a firm decision about which one to start with because they do have overlapping side effects. And sometimes we do worry about whether prior chemotherapy can contribute to worsened low blood counts. There's no concrete evidence for that, but it's definitely a matter of discussion. Sometimes we also find the opposite, which is dual tracer positivity. So as some of you may be aware, pheochromocytomas and paragangliomas fall under the category called neuroendocrine tumors. So they tend to have these receptors called somatostatin receptors on the surface. We look for these somatostatin receptors on a special PET scan called the dotatate PET scan, either a gallium or a copper dotatate PET scan. And if you are positive on those PET scans, similar to the iodine 131, there's another class of radioactive treatments called PRRT or lutetium-177 Lutathera, which is not an approved treatment, but may be an option also. So sometimes when we see both dotatate PET positivity and MIBG scan positivity, it's worth discussing about what would be a better option to start off with. Again, something that needs more studies at this point. I don't think we have a firm answer to that as of yet. But because MIBG, when it's positive, we have an FDA-approved treatment. I think most of us tend to use Azedra before we reach out for off-label treatments. And then a little bit about the future, because we do know that this is a very effective treatment. Even if the response rates, by those definitions, around 25% or so, or 30%, we do see that in terms of quality of life, the boost is pretty dramatic, sometimes immediately, because once the catecholamine surge stops, the patients really feel like themselves and get back to doing the things that they want to do. So we do know that it works well, but what about for the patients who don't have a nice amount of shrinkage? So I think future strategies to think about for us in the field would be how to combine this with other medications, with the hope that combining them may have certain synergies, which and bear greater efficacy than just individual treatments. There is some evidence that blocking this protein called VEGF, which is a protein that the tumors use to build blood supply and to survive hypoxia, that combining this with radioactive treatments, might be a way of improving the efficacy of both of them. Sunitinib is a pill that does, which blocks VEGF. So I think we have a lot of interesting, exciting avenues for research for the future based on that. I'd like to end by just introducing you to my colleagues and a shout out to our multidisciplinary team at Ohio State. On the left is Dr. Barb Miller, who's a world-renowned adrenal surgeon. Dr. Kirshner, who's an endocrinologist, and myself, we form a multidisciplinary clinic where patients can come in and see all of us on the same day and get an expert opinion. And we're very glad that we were designated as a Center of Excellence by Pheo as well for our work. And with that, I will end. I'd like to open to questions, and I thank you for your attention. Thank you very much.
Thank you so much, Doc. I appreciate that very thorough, very in-depth walkthrough in the last 5 years. We had some questions come through during your talk, and then we had some that also came in prior to today. So, first question that came in while you were talking was, have you seen results with bony mets and this therapy? I think you showed an example of it actually in the slides. Yeah.
In fact, that's one of the nice things about it, that the fact that we do get a nice response in the bones, because as we do see, and I think the reason why they asked the question is a lot of our patients, a good chunk of them do tend to have bone-only disease. And sometimes it's, our initial approach is to try and treat the problematic areas with radiation, as PRRT and other forms of radiation. But when we start to find multiple areas that are growing, which cannot be individually treated with radiation, I think, treatments like Azedra, which home in on the tumor, no matter where they are a good option. And we have seen nice improvements in bone disease, with this treatment. So absolutely, there is no reason, why we wouldn't expect that. So it's a good option for folks with bone disease.
Okay, so this is a similar question along that same vein. Somebody is asking on data on how long or effective Azedra is at stopping bone mets from growing and spreading. So very, very similar, same vein. I just want to know the length of time.
Hard to predict, as you can imagine, individual circumstances. But I will say that just based on the trial data, we do see responses that last for years.
Okay.
But on an individual basis, again, exactly how many months or years, it's hard to really state.
Yeah, I mean, sample sizes are low with zebras, right? So, okay, how does PRRT compare to Azedra?
Yeah, excellent question. So I touched upon it briefly, but I didn't want to focus too much on it. But so PRRT, it stands for peptide receptor radiotherapy. And what that really means is you're giving an agent that homes in on a peptide receptor. So what is a peptide receptor? The peptide receptor is SSTR2 that's present on the surface of the tumor. SSTR2 stands for somatostatin receptor 2. So what is the compound? The compound basically is lutetium dotatate. And dotatate is linker molecule that homes in, allows the radioactive compound to home in on the SSTR2 receptor. And the lutetium-177 essentially is the payload. It's the radioactive substance that releases what's called beta radioactivity. And this beta radioactivity is absorbed by the tumor, and the tumors essentially succumb to it. Now, it's a little, superficially it sounds somewhat similar, but it is different because MIBG or Azedra is taken up through what's called a norepinephrine transporter on the surface of the tumor.
Right.
It's not really a receptor. Okay, so when we say PRRT, we are talking about lutetium-177 at this point. Unfortunately, we don't have robust, I would say, clinical trial data of the type that I could show you for Azedra in the PRRT space. So
Right.
it's always a little bit of a challenge to kind of extrapolate from retrospective institutional studies and things of that nature. But I can say that from our experience, we have looked at our patients who have gotten PRRT Lutathera over the last few years. It can cause good responses. We have seen in possibly around maybe 1 in 5 patients or so have a good response. I don't think personally it is as long lasting as Azedra, but I think where the rubber hits the road would be we need a good prospective clinical trial that will exactly tell us how effective it is and duration and things of that nature. But as of today, unfortunately, we don't have that robust clinical trial data to really,
Yeah.
go with. So it is an option. I would say we tend to reserve it for folks who've progressed on more standard options, such as etc.
Progress on more standard options. Do you think in the future people could be possibly combining these medications? You talked about synergies with other medications and stuff. These could be ever used together.
Yeah, not necessarily a PRT and Azedra, mostly because they both act by releasing radioactivity into the tumor. So sometimes we worry because when two kinds of treatments have similar mechanism of action and similar side effects, they both can have bone marrow issues and low blood counts. Those tend to not be the best ones to combine with each other. But
Mhm.
when we have agents that have complementary activity or side effects that are different, then that's an interesting combination. So we do know that, for example, the medication I mentioned, sunitinib, doesn't really have the same issues with blood counts that we see. So I think combining something like that that blocks the tumor's blood supply protein that the tumors use to grow blood supply with a radioactive compound, I think that holds some promise.
Right. Okay. And that makes sense. Okay. Um, Another question that came in beforehand was my son had 2 doses in 2021, and we believe that it saved his life at this point. I am curious. How did she say this? Sorry, I lost my space. Okay, she said, I'm curious. Are data and results continually to be collected by doctors who administer Azedra and shared for the benefit of all patients? Basically, they're saying like, I don't know whether it'd be anecdotally or after the fact. Like, how are doctors seeing the effects of Azedra in a clinical application to see how well it's been working post
Yeah.
FDA approval?
Yeah, the good news is, myself and a few of our other active colleagues and other institutions, we are starting to kind of report our institutional experiences. Now that
Mhm.
we have treated a fair number of patients, we are getting more experience with, controlling side effects, what to expect, how to educate patients, how long the treatments are working. So we are slowly starting to get more, I would call, real world evidence, which is important because sometimes
Mhm.
depending on how clinical trials are designed and administered, sometimes the patient population can be very different from who we see in clinic. So it is
Okay.
important that, as this question says, doctors get together and discuss their personal experiences. And the good news is that is happening at various
Okay.
conferences.
Yeah, it almost seems like when I was reading your background, I think for the thyroid oncology group, you have a multi-institutional registry database for patients with a thyroid cancer. So it's kind of along that same vein. Like, do we have something like for this in this realm? You know.
That's an excellent idea. Not that I'm aware of, but um, for example, in the neuroendocrine tumor space, which I also treat and specialize in, we do have a large multi-institutional registry. that answers exactly the question that you're alluding to, which is, how do folks do on it long term? What are the side effects? What's the quality of life? So I think it's a wonderful idea for the future of creating a registry of our Azedra patients, or just anyone with this disease, because one of the challenges is the rarity. So I think there's just more
Exactly.
strength in numbers if we get together.
Yeah, and the exchange of the information after the fact. Correct. Um, okay, so another question that came in was, how are very extreme labile blood pressures managed?
Yeah. So we have seen that. So with the low specific activity, the earlier generation MIBG, because of the fact that they would block the reuptake receptors and
Right.
without a lot of radiation, a lot of the catecholamines, the norepinephrine would just hang out in the synapse and lead to really high blood pressure when the treatment is administered. Now, the
Right.
good news is because this compound is just so effective and it is so potent, we don't really see that with Azedra. So I have had less of an issue with high blood pressure post administration. Now, what we have started to notice and we are more vigilant about is low blood pressure. So
Mhm.
patients are educated to make sure that they check their blood pressure once or twice a day for the first couple of weeks,
Okay.
because you don't want folks to just resume all of their blood pressure medications, because the medication is just that effective. The Azedra is just that effective that sometimes it's important to radically go down on the blood pressure medicines as and when required. So we have, we ask the patients to maintain a diary and let us know as soon as there's any side effects or any low blood pressures are seen.
Okay.
Occasionally, I have had some patients who require, certain interventions to keep the blood pressure up, specifically if they're having symptoms like dizziness. Um, so compression stockings we have used in some patients with low blood pressure. Very rarely I've had a couple of patients and need to go on something like midodrine or so. A lot of the times it's transient. So,
Mhm.
it happens in the first few weeks, stabilizes in the next few weeks, and then by the time, week 6, week 8 happens, it tends to go away. So that's the good news. We've not had any serious adverse events leading to any complications from that.
Okay, so in the majority of cases, it's just going to be monitoring as standard treatment of care, and then if anything gets out of the ordinary, then you handle it as is.
Yeah.
Okay. These next set of questions are kind of grouped into this section of like, is this treatment good for me? I think a lot of patients are curious when they've tried other things and it's repopulated or it didn't work the first time. So we'll start with this question, and I think they lead off with a very good question that's leading. It says, "Is there any reason why I shouldn't be prescribed Azedra? I ask because my vagal paraganglioma and my right carotid bifurcation is growing. I cannot eat sugar thanks to reactive hypoglycemia, and I have mast cell activation syndrome and EDS, otherwise known as Ehlers-Danlos syndrome. I just want to have my expectations managed."
Yeah. So there are some standard criteria. So the first things first is to understand that sometimes, thankfully, these tumors can be slow growing. So
Yeah.
um, a lot of the times, it's not wrong to keep an eye on the tumors with scans. So many of our patients may have had this experience already that they were diagnosed 10, 15 years ago, and sometimes the tumors are not doing much of anything. So I mean, that's obviously a wonderful place to be at, but I don't necessarily rush and ask for any treatments at that point, because I don't think you necessarily need anything if it's not growing or causing you symptoms or in some ways affecting your quality of life, because you have to balance the risks and the benefits of intervening with any treatment, including Azedra. So let's assume that if the tumors are growing, or if it is affecting your quality of life, or if it is in an area that's causing you problems, such as that you mentioned, I think Azedra is a standard option, provided that you meet certain criteria, which are quite standard. One of them is that the MIBGs can be positive, that you have a nice amount of uptake and concentration in that area. and that you have adequate blood function and kidney numbers, and that it generally makes sense for you in your stage of life and your stage of your disease. So specifically, if there are tumors that can be intervened locally with surgery or radiation, then that's what we would recommend. Or occasionally, sometimes we do try to stabilize tumors with certain, anti-somatostatin shots. So there are certain other treatments that can be started sometimes, which are gentle in terms of side effects. So it needs to be individualized as to who gets the treatment at what stage of their cancer. But just based on those specifics, I don't necessarily see a strong reason why you would not be a candidate. But
Right.
it really depends on all of the other factors that I mentioned.
Yeah. Yeah. And a lot of other questions came in similar to this. Um, they have a paraganglioma that's in a location where they can't, remove it due to safety reasons. Like, so should they consider Azedra? And it sounds like they should be at least talking to their doctor for evaluation, correct?
Yeah. And the right answer may be yes, if, as I said, if there is a reason to intervene, like it's in a sensitive area, if it's causing symptoms, or if it's generally affecting your quality of life, then absolutely. But
Okay.
stable disease, our first instinct is to basically wait and watch if we can afford to do that.
Okay. And I know that can be frustrating for patients too, the wait and watch type of thing when even if it is stable, you know.
Yeah.
Um, and on that end, we have the last question is, does this disease tend to get worse with age?
I think we don't necessarily know the biology exactly as to what happens with time, but I do think that there is some evidence, more than age, that these tumors over time they do tend to figure out ways to grow, and that's the case for not just Pheos and Paras, but any kind of tumor. So over once the tumors become experienced with different kinds of treatments, it tends to activate certain pathways, which tend to lead to resistance.
Mhm.
Specifically in pheochromocytoma paragangliomas, it's most likely what we call epigenetic resistance, meaning it's not that we have new mutations in the tumor per se, but there are certain proteins that control the genes, and those tend to be expressed in a different manner, and this tends to activate certain pathways that allows the tumors to grow and become more aggressive with time. So I think that's broadly true for almost any cancer, and it is also true for Pheos and paragangliomas. um,
Okay.
I wouldn't necessarily say it's age related, but I think it's just the passage of time, and that is irrespective of age.
Okay. All right. I had a question personally on when you were going through the adverse events. Why the blood? Well, why does it affect the SAEs there?
Yeah. Yeah, good question. I think there's probably at least three reasons for that. One of them is related to the first question, which is the bone disease. So we
Okay.
do have a certain subset of patients who have a lot of bone disease, so the radioactivity tends to go there. But the second reason actually is, radioactivity, it tends to actually actively attack tumors, or any cell that's growing fast. And we do know
Okay.
that blood cells are constantly generated, and it's for that
Okay.
reason that some of this radioactivity tends to go to the bone marrow. I think the third possible reason is prior treatments, including if you've had a few rounds of CVD chemotherapy, or let's say more than 13 to 16 cycles of temozolomide. Those are all medications that also tend to affect the bone marrow, so it could be cumulative. So I think there are
Okay.
at least three reasons for.
Okay. Thank you for that. I appreciate it. And thank you for your time and your dedication to our patient community. This was a wonderful talk, a lot of information that we'll probably be watching again and again on YouTube in a few days when the replay of this comes out. Um, we're also going to transcribe the Q&A portion of this, so we'll have that available as well to the patients out there that are very curious. Um, We ask all the patients out there to sign up for our e-news as well as follow us on social media, because there's updates all the time, new key learnings and stuff that we share. We'd love for you to be a part of that. And if this information has been useful to you and you're interested in donating, you can do so at pheopara.org/donate. And lastly, we'd like to give a special thanks to Lantheus Progenics for making this webinar series possible through an educational grant. We really enjoy reaching out with our patients, the physicians, the community in general. As I said earlier, and as the doctor shared, we're so rare. There's not a lot of us. So anytime we can get information, exchange it, digest it, it's very, very helpful. And if any of this information has hit home with any of you guys watching that is carrying the disease or have loved ones with the disease, please bring it up to your doctor and use it as an opportunity for further evaluation. So thank you so much for everyone who attended today.
Thank you, everyone.